Uh, so let me. I guess we only have like 1 minute to go, but let me start by saluting and saying hello to all attendees and all colleagues in Turkey. And personally, I would like to express my deepest appreciation that we have this opportunity to contribute this meeting. And personally, again, I'm so happy to be part of it. And thank you so much for the organization committee giving us this opportunity. And I believe, and I hope this will be a nice start for an upcoming collaboration between your departments, your societies, and our trauma department. So I would like to give the word to my program director, Dr. Kinetol, and I guess it is 8:15. We may get started. Yes, Justin, please. Thank you.
Well, I just want to echo Dr. Alanoglu's statements and say how thankful we are to have this opportunity, especially for WashU to have this session and come and kind of tell you a little bit about how we practice here at WashU. To get us started, Dr. David Moquin, one of our faculty and trauma members, is going to talk to us about emergency airways and trauma. And with that, Dr. Moquin, the floor is yours.
Right. Is there any way that I can share my screen?
David, there's a share screen button on the bottom of your. There should be a bottom of your screen.
It says host disabled participant screen sharing.
All right. Let me tell Dr. Shan. Dr. Shan, we need to host to enable us to share our screens.
Hocam hemen hallediyoruz.
Okay, they are saying that they are okay. They are doing it right now, David.
Perfect.
Here we go. Yeah, we can see your screen right now. Fantastic.
All right. All right, guys. So while I get this pulled up, like Dr. Knittel said, I'm David Moquin. I graduated from medical school at the University of Tennessee in Memphis, Tennessee. I completed my residency at WashU in 2021, so in July of this year. So I'm a new faculty member. My primary interests are airway and trauma, anesthesia for ENT procedures, as well as preoperative assessment and risk stratification. And then I also teach a lot in both with medical students and residents. So I have no financial disclosures. I'm not that important, and I have no conflicts of interest as well. And so my presentation centers around this case. It's a 40-year-old male involved in an unrestrained high-speed motor vehicle accident. He's going approximately 90 miles per hour or 145 kph. He had positive loss of consciousness. His GCS was 6 at the scene. EMS placed him in a seat collar, and he was transported to our trauma critical care unit. In the field, his vitals, he was tachycardic with a heart rate of 110, hypotensive with a BP of 80/40, and he was satting 92%, and EMS placed him on 15 liters non-rebreather for us. And then our EMS people love to share pictures from the scene of the accident, so let's pretend that this was the vehicle. And so as the presentation title alludes to, we're going to talk about airway assessment and how we control the airway in our trauma center. The airway is the first step of the Advanced Trauma Life Support Primary Survey, and for good reason. There are early preventable deaths from airway problems after trauma, and these include failure to adequately assess the airway, failure to recognize the need for an airway intervention, an inability to establish the airway after you recognize that need, the inability to recognize the need for an alternative airway plan after repeated failed intubation attempts, and then failure to recognize an incorrectly placed airway, whether that's supraglottic or esophageal, and then displacement of said airway. And I'm sure, late career anesthesiologists have seen all of these. And if you're early in your career, you'll definitely see a time where there's an airway in place. And as you move over from the stretcher onto a trauma bed, the airway will come loose at some point. So the key considerations when I look at an airway, we always think about their NPO status. We always assume that trauma patients are full stomachs, as if they had just eaten something before they got into the accident or were a victim of trauma. I always worry about cervical spine immobilization, whether they're wearing a C-collar or not, and paying close attention to their mechanism of injury is very important. And then I look at an airway exam, and I try to do this as quickly as possible. If you can look at their Mallampati, great. A lot of times, especially in this patient that we're considering today, you can't. It would be great if you could have them open their mouths and look at their inter-incisor distance. It would be awesome if you could get the thyromental distance, but with a C-collar, that might be difficult as well. The upper lip bite test is my favorite in an awake patient. I think it gives me an easily reliable, objective piece of information that tells me how easy it's going to be to intubate this patient. And then ATLS recommends the Lemon assessment. And so Lemon is an acronym where the L stands for look externally. So you look for a small mouth or an overbite or any sort of facial trauma. The E is evaluate, and they tell you to use the 3-3-2 method, and they want 3 finger breadths of inter-incisor distance, 3 finger breadths between the hyoid and the chin, and then they want 2 finger breadths between the thyroid notch and the floor of the mouth. Now, in a lot of our patients, if they have a C-collar or if they're obese, some of those may be difficult. The M in Lemon stands for Mallampati. The O stands for evidence of obstruction. And then the N is for neck mobility or neck immobility. This is just a picture of the upper lip bite test. And so what you have the patient do is you have them upper part of their lip, just like I did there. Class 1 airway, which is reassuring, is if they can get their mandibular teeth above the vermilion border of the maxillary lip. Class 2 is if they can get their teeth on the lip, but not above the vermilion border. And then class 3 is if they have a frozen mandible in which they can't do that. And that is a very non-reassuring sign for the ease of intubation. And so let's talk about some non-definitive airways. So this patient arrives to our trauma critical care unit with an oropharyngeal airway in place. EMS says that the patient was obstructing. Our EMS comes in a range of skill sets. So some of our paramedics will actually intubate in the field, and some of them are really quite adept at securing airways. Other units are not able to do this. And so we really see the full gamut of people coming through. So let's assume for this case that the patient has an oral airway in place and was obstructing. And so we have to stop and think about what other options there are to relieve obstruction in this patient. And the things that I like to talk about are, can we do non-invasive things like chin lift? But anytime you think about that, you have to worry about their C-spine and whether or not you are actually moving the cervical spine in the setting of an unknown cervical spine injury. You can do jaw thrust, of course, but same consideration with C-spine. You can place an oral airway, but you can't do this on a conscious patient, of course, because of gag reflex. You can insert a nasal airway, which an awake patient may tolerate better, but in trauma, you have to worry about cribriform plate fracture. And then the last non-definitive airway, that is one of my big go-tos is an LMA or a laryngeal mask airway, but same consideration as with the oral airway, you have to worry about consciousness and the gag reflex. And so this picture down on the lower right corner is our standard LMA that we use at our adult hospital. It's an iGel. It's very nice because it's quite firm and acts as its own bite block, so you can't clamp down on it. If you can see the bottom of it at the tip here, I'm not sure if you can see my mouse, but if you can see my cursor, it looks like there's a little conduit here, and that conduit is for an OG tube that you can place down through the LMA and hook to some suction and empty the stomach. I really think that, you know, they're nice and firm. They don't come displaced a lot. They're one of my favorite tools. And so now we'll talk about definitive airways a little bit. So we'll say that the patient's ventilating adequately through the oral airway and is maintaining a 94% oxygen saturation on that 15 liters of non-rebreather. And so we need to think about what a definitive airway actually is. And so a definitive airway, according to ATLS, is defined as a tube that sits in the trachea with the cuff inflated below the vocal cords. And then you want to be able to connect that to an oxygen source, assist their ventilation, and secure it in place. And so that's a lot, but it's something to think about. So really, we're talking about endotracheal tube, whether it's inserted orally or nasally, or surgical airway. And so now we need to think about, does this patient need a definitive airway, right? He's ventilating adequately through the oral airway. But I think we can all agree that this patient needs a definitive airway, but why specifically do they? And so inability to maintain patent airway by other means, inability to maintain adequate oxygen by face mask, or obtundation or combativeness indicating a head injury. So we're talking about GCS less than 8, and this patient had a GCS of 6. And so anytime I prepare to do an intubation, I think of the Benjamin Franklin quote, "Failure to prepare is preparing to fail." And so I use a mnemonic with all of my trainees and myself when I'm working alone, and it's SOAP me. And so the S is for suction, O is for oxygen, A is for airway, whether that's my ET tube or my oral airway. P is for positioning, which is arguably one of the most important things. M is for meds, if I'm going to give any at all. And E is for end-tidal CO2 or equipment. And so really the reason why we think about this is because you want to make your first attempt your best attempt. In an austere environment, you have to have the most experienced person do the procedure because you want the first attempt to be your only attempt. In a controlled setting, like in our trauma bay, I think that the most experienced person just needs to be there and be involved watching. And then the biggest concept, I think, is what's your backup plan if your attempt fails? And what happens if your backup fails? And what if that fails? And so I like to think plan A, plan B, plan C. And so when we approach things, in the majority of our awake patients, we'll do a drug-assisted approach. It just depends on the situation. In trauma, especially with younger people, a lot of us will use ketamine. Our emergency room likes to use etomidate. We rapid sequence everyone because of their NPO status, unless they have an extremely non-reassuring airway exam. For the most part, I use succinylcholine. But if I think that they have a risk for an exaggerated hyperkalemic response, I have no problem using 1.2 mg per kg of rocuronium. And then you need to think about direct versus video laryngoscopy. And I think that most problems with airway can be solved with adequate positioning, an appropriately sized blade, whether it's a Miller blade, if you're more comfortable with that. I prefer a Mac blade, and a gum elastic bougie. In our trauma center, we have the ability to do optical laryngoscopy with a device called the AirTrack, which acts like a periscope and has a conduit to slide the ET tube through, and I'll show you that in a second. You should have a fiber optic bronchoscope nearby, at least, in case that you run into difficult airways. And then you have to be ready to do a cricothyroidotomy, whether by needle or surgical. And so that's just a picture of a gum elastic bougie. As one of my favorite tools. This is our AirTrack. And so this little piece here is the eye hole that you can look through. It has a conduit that needs to be lubed that you place your ET tube in, and you insert it into the mouth and you look down through the eye hole and you should see vocal cords. It's really great for people that have cervical spine immobilization. But this device isn't available at even all of our hospitals. And so you have to be comfortable with whatever you have there. This is our McGrath. It's one of our portable video scopes. We have them in most of our operating rooms and they're easily available. When I'm on call at outside hospitals, I usually grab one from the OR before I go anywhere. And then let's just say, for an example, that our initial attempt by an experienced provider with a laryngoscope fails. We get a grade 4 view with no discernible glottic structures, and you can't even see the epiglottis. And so let's talk about what our options are in this setting. You could bag mask the patient with an oral airway. We knew that they were ventilating before. I'm assuming that we paralyzed them because I did a rapid sequence. If you have the equipment available, I think I would move straight to an AirTrack or a fiber optic. And then you can do an LMA placement as possible fiber optic conduit. And so you can place the LMA, slide your bronchoscope through it, obtain your view, slide through the cords, and then you can railroad the ET tube over as if you were doing a normal intubation. The eye gels are really great for this because the size 5 eye gel, which is for large adults, can not so easily accommodate an 8.0 ET tube, but it can accommodate it. 7.0 very easily, and certainly a 6.0 or smaller. If I do this, the few times that I have done this, I usually leave the whole thing in block and move on with the rest of our exam and what we're doing, and just let the LMA act as a bite block in that case.
David.
And then, yes, sir.
David, I guess we are just a little bit running out of time. Can you please, wrap it?
Yep, absolutely. All right. So we'll talk about surgical airway really quickly.
Yeah.
And so let's assume that the oropharynx is filled with blood and you have no visibility. So what are your options here? So you can do a needle versus a surgical cricothyroidotomy. And you have to remember to use your inline stabilization with this. That's the big key. And so the needle can be done as simply as with just a needle, a 3-way stopcock, and an oxygen source. And what you can do is you can obtain access, hook up the oxygen source to one of your 3-way stopcocks, and you can use the side port of the 3-way stopcock to allow you to jet ventilate the patient. Personally, I think I would just grab a 10 blade and a couple of clamps, make a large vertical incision down the soft tissue, find the cricothyroid membrane, make my horizontal incision, then use the back end of my blade to dilate, insert a gum elastic bougie, and then railroad my ET tube over it. I have never actually done this on a live human being, so take that with a grain of salt. But basically, our take-home points for this is you need to rapidly assess the patient. You need to have multiple plans, and you need to know who you're working with, if you're working with anybody, and what your equipment is, if you have anything but a direct blade. And remember to keep your cervical spine immobilized. And I'm sorry for running over. This is my contact information if you'd like to talk to me about anything. I didn't leave you very much time for questions, but if you have any, I'd be happy to take them.
Well, thank you, Dr. Moquin. We do have a couple minutes, so if people do have questions, please raise your hand, or if you want to type it in the chat, we'll moderate it and be able to pass on the questions to the speaker as well. Just as another reminder, please mute your microphones if you're not the one speaking.
May I have a question? If there's,
Yep.
I can't see anything running right now. So David, thank you so much for your excellent presentation. Appreciate it. So, you know, most of the time, as you also already stated, we have patients intubated or an airway managed by the paramedics and other people or the ED people. So what do you think about the involvement of the anesthesiologist, the trauma anesthesiologist, especially in the ED, about the airway management? So what kind of a role we have in the ED settings for the airway management?
You know, I think we range from either the, on the far end, the practitioner placing the airway, down to important resources for EMS. I think it's great that our EMS providers are able to intubate patients safely. Yeah. I think we have a huge role to play in education, because at the end of the day, we are airway specialists. And at the very least, we need to be involved in education. I know that at our institution, we spend a lot of time helping our emergency medicine residents learn airway skills in the trauma bay.
Yeah, thank you.
Thank you guys so much for inviting me. It was really great to be here.
Zekeriya hocam, sizden yardım alabilir miyim?
Yes, please. Hocam buyurun. I will translate it. I will translate it. Sure, go ahead.
Mr. Nittel ve tüm arkadaşlara, hocalarıma çok teşekkür ediyorum. Bizi bugün böyle
I would like to thank everyone. Yes.
Ben şunu sormak istiyorum. Bir acil masası, acil arabası gibi boyunluğu takılmış, travmalı bir hastaya geldiğinde bu hastayı mutlaka video laringoskopla ya da işte şununla entübe edeceğiz diye oturmuş bir anlayışınız, bir şeyiniz var mı? Yaklaşımınız var mı?
Okay. So the question is, whenever a patient show up with a collar on, in a trauma patient, do you have a certain algorithm or a preference of using a video laryngoscope or something else for the first line choice of the airway management?
I think it entirely depends on where you are. Personally, I jump straight to AirTrack if they have a C-collar on, because that's a tool that I use almost weekly. I'm very comfortable with it. If I didn't have it, I would use a video laryngoscope, and I would probably have a bougie as my first line.
Perfect.
Thank you.
Hocam zaman varsa bir soru da ben sormak istiyorum.
Yes, sir. Please.
You said your first choice for the supraglottic airway is iGel. What is the second option if you don't have iGel?
So here we have the LMA Unique as well. It's nice because you can inflate the cuff a little bit after you place it, but I think that we get better seals with the iGel, in my opinion.
Thank you.
All right. Just for the sake of time, I think we're going to move on to our next speaker. If you do have any other questions about airway, you can type it in the chat or send us a note, and we'll try and get you a response from Dr. Mokwin. So I just want to introduce our next speaker. It's Dr. Manjab Sidhu. He is one of our resident anesthesiologists here at WashU, who definitely has an interest in trauma, and I'm sure he's going to be practicing in trauma at some point in his career. And he's going to be talking to us about cranial trauma. So with that, Dr. Sidhu, and again, just as a reminder, if you have questions, you can type them in the chat or raise your hand so we know to call on you during the discussion part. And if you're coming into the room, please try and mute your microphone.
Okay, cool. Thank you so much. Thank you for having me this morning. Can everyone see my screen? Yes. Cool. Awesome. Great. So I'm going to quickly talk about the ABCs of cranial trauma and what we're looking at from our end when we're working with both our surgical colleagues and our colleagues in the emergency department when these patients initially come in, and what our thinking is as we kind of transition that care through multiple teams. I don't have anything to disclose. And so I think with anything, it's always good, just as Dr. Mokwin did as well, to put things in perspective in the case. So this is something that a very similar case I recently encountered. So we had a otherwise healthy 30-year-old gentleman who presented to our emergency department. He had an unwitnessed ground level fall. EMS reported to us that he was completely unresponsive, had unequal pupils, had a GCS of 5. When he initially came in, his heart rate was 90, blood pressure was fine. He was satting 98%. His respiratory rate was only 7, though, had only one very small injury on his head. And one thing that was very noticeable when he came in, he did not have a definitive airway like we were just talking about. But he was having this like very irregular pattern of breathing. He had very shallow respirations. And so everyone jumped to, what's the next thing we're going to do? As Dr. Mokwin just so excellently spoke about, certainly the next thing we want to do, regardless of, just given this clinical scenario, is we want to secure our airway. Now, in patients who, we suspect of having some head trauma, given this patient's, clinical history and just kind of the way he presented and what the injury was reported to us, how are we going to manage airways in these patients? It's really not much different from what Dr. Mokwin was talking about before. We're going to do a rapid sequence induction and intubation. You can use propofol, etomidate, ketamine, like here at WashU. Our emergency department colleagues like to use etomidate a lot when first inducing. As well, they use succinylcholine. Now, there is maybe a little bit of concern that there's some depolarizing, that the depolarizing neuromuscular blockers may increase your intracranial pressure, and I'll talk about why it's important in a second. But all in all, if you're really concerned about it, you can also give a small defasciculating dose of something like rocuronium and then proceed with succinylcholine so you can rapidly intubate this patient and really secure that airway as soon as possible. And then, like we were kind of talking about, use of video laryngoscopy is definitely recommended in this situation, because a lot of times with cranial trauma, you also have a high concern for cervical spine injury as well. So you want to try to, get that tube in as safely as possible without compromising any spine function or worsening any possible injuries that are in that setting. Now, once you have the airway in place, the next question is, well, what are we going to do, right? And I think this is an important place where you need to step back for a second and think about, well, why did we do this all in the first place, and then specifically for this patient in particular? And that's where we have to start thinking about, what are we concerned about with patients who have acute traumatic brain injury? So with any type of trauma, you're going to have, on a cellular level, inflammation, you have bleeding, of course, and in the brain in particular, what we're concerned about is elevated intracranial pressure, right? So when we have any type of injury to the head, right, we're going to be concerned about swelling and bleeding in the intracranial vault. And so what that does is, as you can imagine, you're going to have less pressure being able to actually perfuse the brain, because you have this increased pressure in the cranium itself. And so what that does is it causes a buildup of CO2, causes more cerebral vasodilation. And then as a result, as you're moving along, it's kind of a vicious cycle. You have more vasodilation, more building up of pressure. And what eventually happens is your body says, oh, I need to start increasing my perfusion pressure to my brain. So what it'll do is your sympathetic nervous system will kick in. You'll have hypertension, and then starting to have a wide impulse pressure as well. As any time you have, hypertension, you're going to start having a baroreceptor reflex. That's going to cause some bradycardia. And then lastly, the actual intracranial pressure will also cause some pressure on the respiratory center and the brainstem, and that can also result in irregular breathing. When we look at these three things together, bradycardia, hypertension with the wide impulse pressure, and irregular breathing, those three things together is what we call Cushing's triad. And so those are clinical signs that, this brain injury is worsening. And that's where we really actually come in as trauma anesthesiologists to try to do everything we can and use different strategies to prevent this from worsening. So once we have the actual tube in place, what are we going to do for these patients? First thing is we're going to hyperventilate them. That's so that we can reduce CO2, and that results in cerebral vasoconstriction. The thought being that's going to drive down your actual intracranial pressure. Our goal, CO2 is going to be 30 to 35, and sorry. And then whenever we usually use end-tidal CO2 as a marker for where we're at, but it's always important in these patients to make sure you have a blood gas so you can actually check that gradient so you have a better sense of what's going on, because this is so important in these patients. Now, it's always important to also be mindful of the fact that when you are hyperventilating these patients and we have some cerebral vasoconstriction, how we're doing it, because you don't want it to go too low, because that can then also result in cerebral ischemia in a brain that already just had an acute injury. And then, of course, always making sure that you're having adequate oxygenation, and you can utilize your blood gases for that as well. So back to the patient that I was just talking about. In the emergency department, a CT head was performed, and it revealed an epidural and subdural hematoma with accompanying midline shift. You can kind of see this here. These are the actual images. You can see a midline shift right here. You can see a hematoma right here as well. And that, along with his clinical situation where he was unresponsive, his breathing pattern had worsened, the decision was made to go to the OR emergently. So this is just like a good point just to talk briefly about why we want to go to the OR emergently, and kind of, this kind of scenario hits on both places, pretty well. So first is any type of intracranial hemorrhage or intracranial swelling resulting in midline shift like we saw here. And then for our gentleman also, he had clinical signs of decompensation and deterioration. And so those were signs that we should go to the operating room emergently. Now that we're heading to the operating room, what are we going to start thinking about? We're of course going to want our standard monitors, but we definitely want to make sure that we have a close monitoring of temperature, because hypothermia is not good for these patients at all. Also, because it's a trauma, of course, and we want to make sure we're prepared. We want to make sure we have sufficient vascular access. So a couple large bore IVs. Usually here we try to have at least two 18s, or an 18 and a 16. Additionally, we always place an arterial line. That's so that we can have good monitoring of blood pressure, since that's really important to thinking about how we're perfusing the brain. Also allows us to get good blood sampling, like I was talking before about getting blood gas as well, to see where our PaCO2 is. Anesthetic maintenance can be used with either inhaled anesthetic or Ativa. Commonly here, we'll bring the patient up, put them on gas, and we really don't have any trouble with that. And then we usually do give seizure prophylaxis. Here we do Keppra, and then we'll also do osmotic diuretics such as mannitol prior to incision. The osmotic diuretics help reduce the intracranial pressure. Seizure prophylaxis, of course, just given the fact that they just had a brain injury. And then if the patient is hemodynamically stable, an opioid infusion or boluses are okay. I've used hydromorphone before. I've done the fentanyl infusion before, so that's okay for analgesia as well. And so those are just things to think about. The last kind of C is circulation, of course. And so this is where we really need to think about, well, now that we have the patient anesthetized, how we're going to manage their hemodynamics. So first thing is always making sure that their systolic blood pressure is greater than 110. This is really important because that's going to play a big component how we're making sure we're actually having a good cerebral perfusion pressure. Now, if our intracranial pressure is severely elevated, to make up for that, you might have to drive your cerebral perfusion pressure a little bit higher. Let's see. You can use vasopressors to increase the systolic blood pressure in the map as well. We try not to use fluids because, we've just diuresed them to reduce that pressure. So vasopressors such as phenylephrine are really great. That's what we commonly use here. And I think, that works really well. If you do have to give fluids, crystalloids definitely recommended over colloid. I know there's been the SAFE trial, and that's mentioned that as well. And in general, I think it's in any type of trauma, using crystalloid over colloid is a better choice. And then, the other thing we need to keep in mind is patients with acute traumatic brain injury may also have significant intracranial bleeding as well. And so, a lot of times what'll happen is they'll open up the head and a lot of blood will all come out immediately. And a lot of times your labs aren't going to reflect that because it's just whole blood. And so you really have to look at the clinical picture and what's happening on the field and kind of get ahead of that a lot of times in terms of transfusing. The other thing is, if patients keep bleeding, but for example, their platelets look okay, everything's okay, we have to think about, are their platelets actually working, right? So utilizing tests like thromboelastography or ROTEM to make sure that functional platelets are present may also help with hemorrhage as well. So our big take-home points, make sure we're establishing the airway in these patients early so we can use ventilation strategies to help control the injury and also for airway protection. We want to maintain an adequate cerebral perfusion pressure by reducing our intracranial pressure and increasing our mean arterial pressure. We do this through a multitude of strategies. And then also make sure you're having sufficient vascular access for these patients because they can require rapid resuscitation and there's always going to be concern for hemorrhage. And so with that, thank you very much. And I'm open to questions.
Thank you very much, Dr. Sadhu. Does anyone have any questions? I know we have one in the chat. I'll let Dr. Alanoglu address that or introduce it.
Yeah, there's one question from the audience. It is mainly about the use of ketamine for the rapid sequence anesthesia induction in patients with head trauma. So do we have any, role of ketamine for the anesthesia induction? And what's your opinion about this thing, Dr. Sidhu?
So I've seen, I think that our colleagues in the emergency department, if it's a younger patient, I've seen them use ketamine before. Now, of course, I think there's some thought that if you're using ketamine, it's actually going to cause more, brain activity and can cause more metabolic stress on the brain. Yeah. But I've seen it used before. I don't really have any good evidence. I don't know if Dr. Canitto can talk more about that.
I personally use it. And I think my take is I think it's a little overblown, its effect on, specifically the ICP. So I'm not scared to use it in these patients. And I think you have to keep the patient alive to keep the brain alive. So if this gives us some hemodynamic stability to get through induction, that's the best thing we can do for the brain.
Bekir Hocam izin verirseniz bir katkıda bulunabilir miyim?
Tabii, yes, sir, please, Dr. Kota, please.
The information that ketamine is contraindicated in head trauma comes from very old literatures with less than 10 patients generally, and yes, with cerebrospinal fluid obstruction. So in reality, the ketamine protects the brain because one episode of hypotension makes prognosis of head trauma patients worse. So I agree with Dr. Clinton that we can use ketamine safely in these patients.
Yeah.
But if you are afraid of using ketamine alone, combine with propofol, like the American Army do ketofol.
Yeah. So if I may, Dr. Sidhu, and we have that, as far as I can see, we have a couple of more minutes to go. Can you give us some insight? What kind of a OR organization in terms of anesthesia we have in WashU for emergent cranes or emergent, head trauma patients on the ORs? What kind of a setup we have? Do we have a dedicated room?
Yeah. So
what do we have?
We have one dedicated room here, usually specifically for head traumas. We have other rooms that are specifically for most of our other traumas. We have one specific room for head trauma. So that those teams can come in pretty quickly. They're always here, so those rooms they're already pre-set up from our end usually. And if a head trauma comes in, we can get up there pretty quickly within 20, 30 minutes at the most. Usually what happens is the rate limiting step in a lot of that time is getting the imaging, right? Because the clinical situation is very apparent that, oh, this is, some type of head trauma. And our head trauma here in the United States, sadly, is also not just simply, blunt head trauma, but we also have a lot of gunshot trauma to the head as well. And so, that's a little bit different, but same thing. You want to see what the imaging shows, whether this is a good operative candidate for the neurosurgery team. But once we have that imaging, we can get started pretty quickly. Fortunately for us, I think what Dr. Moklin had alluded to already was that a lot of times our patients are either already have a secure airway, either from the emergency medical services team or our colleagues down in the emergency department. So for us, it's coming up, making sure we usually get some additional vascular access. We, get a arterial line usually, and then we're quickly able to move along with our cases.
Okay, Dr. Sidhu, there's one last question, and we only have like a minute. Let me translate it. It is saying that we have to keep the cerebral perfusion pressure and optimum with the mean arterial pressure. So what are your options to prevent the hypotensive patient having low mean arterial pressures, which will be impacting cerebral perfusion pressure?
You said hypotensive patient, correct?
Yes, in a hypotensive patient, what are your options?
So usually
optimize it.
So usually, honestly, the way I've thought about it, at least, is you can either, right? So we've diuresed the patient, right? We've taken fluid off because we want to give some space to the brain. So usually my first thought is this is a place where we can it's okay to just use vasopressors to drive that pressure up. So a lot of times, because we have peripheral IVs, we'll use phenylephrine. A lot of our patients are, sadly young and, otherwise healthy. And so they'll come in and they'll respond pretty well to things like phenylephrine. So pressors are usually our first number one, and then you'll see a lot of times in our ICUs when you have invasive monitoring of your intracranial pressures, that gives us even a better tool to then titrate how we're using our pressors to balance our CPP.
All right, thank you so much. I guess we are out of time, for this presentation. So I just pass the word to Dr. Kinnital for the next presenter.
Yep. So thank you very much, Dr. Sidhu, again for that. And we'll move on to the next talk. Dr. Chris Murphy is one of our trauma faculty and intensivists, and he's going to be talking about thoracic trauma. And so with that, are you able to share your screen?
Yeah, let's give it a go.
Okay, perfect. The floor is yours.
All right. So yeah, I will cover thoracic trauma. All right, y'all seeing my screen now? All right, so thoracic trauma, very broad topic. I can't limit it to one case because it's such a broad topic. So we'll do a brief introduction, go through some data, and then get into some specific mechanisms. So like I said, covers a lot of things, broad range of injuries, significant morbidity, mortality. So these people are at high risk to do well. This comprises 20 to 25% of traumas worldwide. Here in the United States, it's 35% of trauma-related deaths. And you can break it down, to make it oversimplified, you can break it down into blunt versus penetrating trauma. More commonly worldwide, you're going to be dealing with blunt trauma. And in these patients, especially for us as anesthesiologists, the initial evaluation is going to be the most important step. So us as trauma anesthesiologists, when we're reporting to the trauma bay with the rest of the trauma team, the second we walk in the door and lay eyes on a patient, that's going to be one of the most important steps. So the anatomy, so what we're looking at here is that's a lot of structures in a very small fixed space. Very rigid boundaries. And it's going to serve two purposes that we all know. It's going to facilitate respirations, and it's going to protect all those structures from external injuries. So when you get to blunt thoracic trauma, keeping all that in mind, the main cause of injury here is you're going to have a very rapid deceleration. So your two mechanisms, the mechanisms that we'll see here are MVCs, especially those that are high speed patients or people who are not wearing a seatbelt, extensive damage to the vehicle, or if there's prolonged extrication, any deformity to the steering wheel, or any other body part that, any other organ system or body part that's been injured. Other things that we'll see, falls for younger patients who come in. This is going to be a fall. What we see a lot of around here is people falling off ladders, people falling from trees. For elder Americans, this can be a fall from standing. Elder patients, it can be a fall from standing. And then you can see assault or a direct chest impact. So populations at risk for major trauma in the blunt category. Like I said, elderly patients greater than 65 years old. For those patients with, especially with osteoporosis, a fall from standing is enough to do some major damage. And then, like I said, people in the front seat, people not wearing seat belts, and then high speeds. So over 40 kilometers an hour. The most common injuries that you're going to see with blunt thoracic trauma is chest wall injuries. So lots of rib fractures. Keep in mind, so rib fractures, and then with that you get flailed chest from time to time, and then pneumothorax, hemothorax, pulmonary contusion, and then the most dreaded one that we all keep in the back of our mind, blunt aortic injury. A lot of these things can be managed non-operatively. So for us as anesthesiologists, we walk in the room and we always, when I walk into a trauma, I'm always preparing for, okay, if this person comes to the OR, I've got to keep this in mind. But a lot of these things can be managed non-operatively. We can focus on walking into the room, laying eyes on the patient, and say, okay, how is our airway here? This could be preparing for a possible difficult airway. But appearances can be deceiving. So you can walk into the room and the patient looks fine initially, but these people are at high risk for decompensation in the first 1 to 2 days. So those patients are going to be the ones over 65. If you walk into the room and their pulse oximetry is sitting at 92% or less, if they're unable to take good tidal volume on incentive spirometer, or multiple rib fractures. So moving to penetrating thoracic trauma. So by definition here, the chest wall has been violated. This is less common for what we see here, but this is a lot more dangerous. Every structure in the chest is equally susceptible. Where we really get nervous is if you look at the cardiac box there. So in between your clavicles, from your midclavicular line, and then between your midclavicular lines, and then from your clavicle to your xiphoid, everything in there, you're looking at, if you've got a penetrating injury, if you see an entry site there, you're at a higher risk for a cardiac injury and tamponade. And in the acute setting, all it takes is 100 cc's of blood or less to cause tamponade. So for these, your injury is going to depend on the location and the trajectory. You're going to want large bore IV access. These patients can lose a lot of blood very fast. So you're going to want large bore IV access and then blood on hand. Imaging is hugely important here. Here, patients will get the fast scan in the trauma bay. We can extend that and get views of the chest with the eFast. And then, of course, the CT scan will give us a great idea, it will give the team a great idea of what we're dealing with and exactly the trajectory and the damage that's been caused. And then communication with the surgeon, with the trauma surgeons, early chest tubes here to prevent tension physiology and any decompensation from that standpoint. So, like I said, the initial assessment here is the most important part. So when we walk into the room, that's when it starts. We want to identify any major injuries that can be immediately life-threatening, and we want to intervene on those immediately. So the big ones will be tension pneumothorax, cardiac tamponade, aortic injury, or any kind of damage to the airway. And then beyond that, you get into working into the secondary survey. So some signs for surgical intervention beyond a chest tube. that be it a thoracotomy versus a VATS, if you're dealing with massive hemothorax of over 1.5 liters of blood loss, if you've got a chest tube that's putting out 200 cc's an hour over 3 hours, cardiac tamponade, or any kind of an airway injury. Those are times that you want to make sure you've got great communication with your surgical colleagues and you're preparing in your mind as an anesthesiologist for, we need to get to the operating room sooner rather than later, and make sure we've got good IV access and prepare for that. Any kind of bleeding in these situations is usually due to a lacerated intercostal artery, so keep that in mind. And then, like I said, management here, airway is paramount. So you want to prepare for a possible difficult airway right off the bat. As soon as you walk in the room, you're assessing the patency. So is the patient comfortable? Are they showing any signs of respiratory distress? Or is there stridor? If so, we need to be in contact. We need to communicate with the room and say, hey, we need to deal with this sooner rather than later, before things get out of hand. And then once we've ruled out or dealt with the serious injuries, your pneumothoraces, hemothoraces, things like that, you move to your secondary survey and get imaging and deal with anything that comes up there. So chest, 80% of your injuries will be managed with the chest tube. And then these patients admit sooner rather than later for respiratory monitoring, because like I said, a lot of times they'll get worse before they get better. And then as anesthesiologists, we can be important here because pain control is huge. These patients will have poor compliance and it's going to be painful to breathe. So we can offer our expertise in that way and hopefully avoid some ICU admissions or some intubations. So just a summary, it's a broad topic of injuries, a broad category of injuries that you can break down into 2 categories. But it's a category where things can go wrong very quickly. So your initial evaluation is the most important part. When you walk in the room, you want to make sure you have a patent airway. Is this a possible difficult airway? And then rule out any injuries that can be catastrophic right off the bat. And then just continuous evaluation of the patency of the airway and communication with the rest of the team. And then keeping in mind that these patients can often get worse before they get better. And with that, I'll open it up for questions.
Well, Dr. Murphy, thank you very much for that presentation. We can open up the chat and for any questions that people may have, or raise your hand. I'll start off real quick. When you see a report, we normally get a little bit of a heads up before a trauma comes in terms of what the injuries may be. If you see thoracic trauma or some sign of thoracic injury, what's your approach to access?
Like I said earlier, I want 2 large bore IVs, right off the bat. These cases, especially if you're planning for, if it's a thoracic trauma and you're thinking going to the operating room, that's a very vascular space, especially when you're getting into thoracotomy territory. And if they're getting into the mediastinum, that's an area where you can lose a lot of blood really fast. So large bore IVs, if I can get a rapid infusion catheter, even better, that would be ideal. And then definitely working on, talking with the surgical colleagues and establishing some kind of central access, because if you're losing blood products that fast, no matter how fast you can replete blood and try and keep up the blood loss, you can imagine there's going to be some need for vasopressors and reliable IV access. So rapid infusion catheters are huge. Any kind of a introducer or a central line, even better.
Does your location for the central line change that, knowing that you have thoracic trauma?
Yes. So if you're dealing with thoracic trauma, yeah. Obviously, I'm going to you're going to stay away from your subclavians. That's likely going to be in the surgical field. If you're dealing with thoracic trauma to that extent, you may have some C-spine injury, so it's going to be hard to get access to your internal jugular. So femoral, while we get nervous about it in the ICU standpoint from an infection degree, from an infection prevention standpoint, it's there, it's easy, it's easy access. Your surgical colleagues can work, can access that for you while you're preparing the airway and obtaining access elsewhere.
Thank you
I
very
guess
much.
No comments or no questions in the chat. So
No, we're a little early. I guess we
let's
could,
proceed.
I am curious if you want to go into a little bit more about the imaging part of things. And you said that's really valuable in these thoracic injuries. And I know you mentioned EFAST. What would your approach be, especially how, I guess, I'm assuming you think ultrasound is probably a very valuable resource here.
Yes, it is. It's something where we're getting better with it all the time. And with TEE becoming more available, that's certainly another tool that you have. You can get a good, more windows of the heart, more windows of the aorta if you're concerned for aortic injury. CT scan is the go-to because just about every patient who comes in through the door in these situations is going to get one. But ultrasound is there. It's quick, it's easy, and if you've got a patient who's potentially unstable, we don't have to get them out of a critical care area like a trauma bay or an operating room to do it.
And at least shows you some of these things, such as, diagnosing a pneumothorax very quickly,
Right.
diagnosing tamponade very quickly, in some cases can even see the aorta and diagnose an aortic problem. So yeah, definitely a skill set that, we're seeing more and more and utilizing more and more in the trauma bay without the need for a scanner. We normally have an idea of what's going on beforehand. Yeah, and these are definitely patients that, you're right. Most of the time, they're not going to come to the operating room, but when they do, it's normally very bad. So.
Yes.
Any other questions, any other comments that we can pass on to Dr. Murphy?
If I may, I would like to make a small contribution. We are really super, privileged that we have a easy access, as you already mentioned, and Dr. Murphy already mentioned, easy access to T. And on top of it, we don't only have easy access, but we also have a great opportunity that we have skilled, colleagues around all, 7/24 and around the clock that they can give us a hand to interpret in case we need an expert opinion. So this is very important for a well-structured trauma team because it's not just the anesthesiologist, just the surgeon, but also the supporting team is super important. Whenever you need some expert opinion, you can access and you can ask them to, show up and then just give you a critical information in case you need some more extra hands. So we are always privileged to have those colleagues all around and just helping us. I would want to underline the importance of the background team, which not almost ready for help, but not always on the scene, but just ready to give us a hand. So I'm super happy to have them. So
absolutely. Yeah. I mean, trauma is a multidisciplinary approach.
Yes.
To do it well.
Absolutely.
And we're very fortunate here to have good collaboration with our other colleagues. I know we're a couple minutes early, but we can move on to the next talk. Dr. Mitch Fingerman is kind of a jack of all trades here at WashU and is on the trauma faculty, also serves, does regional anesthesia extensively, and is one of our division chiefs in the department. And he is going to be talking to us about abdominal trauma. And so with that, I'll open up the floor to you, Dr. Fingerman.
Okay. Can people hear me and see the slides?
See the slides,
yes.
And we can hear you.
Great. My name is Mitch Fingerman. Again, I'm Division Chief of Regional and Ambulatory Anesthesia here at WashU. And like Dr. Knittel had mentioned that I probably do trauma about 5 to 7 times a month in various capacities. A lot of times on weekends, which is always challenging because we don't always have the full armamentarium around, and we gunshot wounds and abdominal trauma are 24/7, obviously. So we're going to talk to you today about abdominal trauma and anesthesia. My disclosures, I'm on the Speakers Bureau for Avanos Medical. This has no direct bearing or influence on the talk today. These are actually regional anesthesia supplies. So a little bit of an overview to give you an introduction to sort of the epidemiology of trauma, similar to what Dr. Murphy had just done. Talk about the anatomy of the abdomen, just to show you how many vital structures are in there, just like a lot of other compartments like thoracic region. Mechanistically, we'll talk about the mechanism of injury, and then we'll talk about assessment. What can we do as anesthesia providers, and what do we do here at Barnes-Jewish Hospital, Washington University, as well as the management and triage perioperatively for abdominal trauma patients. So it's abdominal trauma is obviously it's very common, and we see this multiple times a day typically. A lot of gunshot wounds, and this can lead to obviously significant morbidity and mortality. There's two main forms. Blunt is about 80% of abdominal trauma, and those can be a little scary because it may not present immediately with issues, and it may present sort of an insidious presentation, a little delayed onset. These are more common in UK, Australia, New Zealand, and most of Europe. Unfortunately, in the United States, South Africa, and many South American countries, we deal with a lot of penetrating trauma, specifically being gunshot wounds. There's really two major mortality peaks. Dr. Cowley, who's considered one of the fathers of emergency medicine and trauma medicine, spoke about the golden hour, which means that sort of the first 60 minutes of trauma, optimally, you want to get patients into a triage bay within 10 minutes of injury, which is a bit optimistic, but we really want to be dealing with hemorrhage control within 15 minutes of arrival, whether that be direct pressure, using something like a Roboa device, which is sort of an occlusive vascular device that you can put in someone's aorta. But you want to get down them early in the ER and even immediately to the OR. Sometimes patients come in and they're within the ER within 10 minutes, they're up in the operating room. And we have a dedicated trauma room, typically on the second floor, which is basically people come express up there very quickly sometimes. Later on, the mortality peaks with both SIRS, we get this systemic inflammatory response, or also you can see multiple organ dysfunction, just multi-organ failure. The anatomy obviously is really extensive. People can see my cursor. You can see you have multiple compartments here. You're dealing with the diaphragm, the liver, and the spleen, both highly vascular areas. Peritoneally, you're dealing with a lot of hollow viscous, obviously. I think I want to highlight the retroperitoneal space can be quite scary because you're dealing with very large vessels in the aorta and the IVC. And a lot of these retroperitoneal bleeds can be very occult. You may think that you're dealing with something that's very small and very minor, and the patient can collect up to 2 liters of blood in their retroperitoneal space, and we don't even pick up on it right away. Especially if they're coming upstairs. Obviously, fast exams can be used, but they may not always pick up retroperitoneal bleeds. In fact, often they don't because we're really not looking in that area. Pelvic space, obviously, whenever you're dealing with the abdomen, you always have to consider thoracic and pelvic injuries as well. If it's based upon, your lungs are inhaling and exhaling, so you may have your diaphragm may be hit. Also, bullets ricochet all the time, and you can see various types of seismic effects that we'll talk about. The upper levels of the diaphragm, inferiorly, you're dealing with the inguinal ligament, and laterally, the anterior axillary lines. And I mentioned that, being the lung is a dynamic structure, you may have other involvement, more so into the lung. You can see hemothorax and pneumothorax with these patients as well. Think specifically about the blunt mechanism. You can see compression of solid organs from steering wheels and seat belts, less often baseball bats, but liver and spleen, obviously being very vascular structures, these can bleed a lot. Compression of hollow organs, and you could see both rupture and peritoneal contamination. The deceleration injuries, which Dr. Murphy had alluded to, these can be specifically, you could see with liver and spleen lacerations. These are sort of organs that are fixated with ligaments that if you basically pull on them or decelerate them, they can shear a lot. as well as you can see mesenteric bleeds. We've seen some mesenteric injuries which bleed tremendously. From penetrating standpoint, we see less often stab wounds. Oftentimes, the knives that are employed are sort of not sort of big, large knives, so they don't typically get too far intraperitoneally, if at all. Gunshot wounds, obviously being high velocity. Gunshot bullets do tons of injury, both direct laceration as well as what we see, this cavitation effect. The bullets create both a permanent and temporary cavity. And you also see sort of shockwave injury that may not even be near the bullet entry or exit site. Just your whole body sort of experiences almost like an earthquake. You can see large disruption of tissue. Both solid and hollow organs can be affected. Obviously, we're assuming that the patient is going to come in on a full stomach, so hollow organs oftentimes are not spared because they may suffer considerable damage if fluid filled. This is just sort of a mechanistic diagram of what a bullet can do. I think the take-home point, we're not here to talk too much about ballistics medicine, is the fact that very small holes, and I've been doing this now for about 15 years, very small holes can lead to really big problems, and it's very hard to judge. If you see, a small little injury, looks like a BB gun, like a little pellet, but we've seen some of those folks have had the worst outcomes. And some people that have very large injuries at the surface don't have much injury down below. And this is due to multiple factors, both the gauge of the bullet, the caliber of the vessel, caliber of the weapon that's used, and also quite frankly, the size of the patient. If you take a morbidly obese patient who gets shot, it may get stuck in their adipose and not really get intraperitoneally, but someone who's small and thin, you can do a lot of damage. And what can we do as anesthesiologists in trauma? I take a very active role. I typically, when we get a level 1 trauma that comes in, it comes across our pager. I typically go down, typically with a senior resident, and we're just dealing with standard ATLS. So we're looking at airway. Obviously, the airway in the ER, like was talked about earlier in Dr. Moklin's talk, is typically dealt with by emergency room providers here, but we can get involved if needed. The breathing and ventilation we deal with basically up in the operating room. I think circulation with hemorrhage control is critical in abdominal trauma. Like I said, a lot of this is both visible and occult, sort of unknown blood loss that you can see. Looking at disability and neurological status. And really, I think we play a strong role with both in the E of this, in exposure and environmental control. And I know that Dr. Knittel and Dr. Alanoglu can speak to this as well. Oftentimes, we may be the first ones discovering other bullet wounds in the operating room. I could think of a case last weekend where this patient was shot what we thought was 5 times, but we discovered 2 more bullet injuries during the surgery, including one from the back of this patient's neck. We're focused on abdominal and thoracic injuries, but this gentleman was shot also on the back of his neck, which actually, and even in the face, which wasn't initially picked up. So we need to have early involvement in the trauma room, and we're part of this multidisciplinary trauma team. I think we function quite well here at Orange Jewish at Washington University. Obviously, we're doing rapid sequence for many reasons, not only full stomach, but these folks can have high abdominal pressures from both hemo and pneumoperitoneum. We want to ventilate appropriately and send blood gases. Typically, we're doing arterial lines. I mean, we do have stable abdominal trauma where we may forego this if someone's young and otherwise what we assume is healthy. We may not always put an arterial line in, but a lot of it is based upon hemodynamic stability and comorbidities. I think we talked about in earlier talks, the adequate of IV access is imperative in these individuals. And I think in the past, a lot of times femoral access was obtained with sometimes bad outcomes, because obviously that they're working in the abdomen, they may have an occult IVC injury or even a known IVC injury, and all this fluid efforts and blood products are just draining into their peritoneum and not really getting to where it needs to be. So it's important that veins drain into the SVC. Large bore access, sometimes even IOs are used if we can't establish good access right away. And We oftentimes use Belmonts, which rapid infuser devices, and also mass transfusion protocol can be employed. Last weekend, we ended up using 5 boxes of blood during mass transfusion protocol. So it is not uncommon to employ that. I think overall, this is a very dynamic situation between anesthesia and surgery. Very important to have early involvement, and very important that we're all clear on what the key injuries are. I think, you know, when I think we work well here, I think we have surgeons that communicate. We need to communicate as well. We don't want to have any surprises later in the case, like, oh, by the way, I see another bullet wound here. Oftentimes we can help triage these such situations. We also have multiple specialties involved. Oftentimes it's general, which is trauma surgery here, but we may have interventional radiology where sometimes patients may start in the OR and go to the IR suite or vice versa. So we just need to coordinate. Each one of these specialties has sort of different parameters and goals on managing care. I think the most important thing is planning ahead. You know, we have a trauma room that's set up. You know, it's always good to have plan B, C, and D, to be flexible and to work as a team. Obviously, we're a teaching facility. It's delegating appropriate tasks where we're sort of empowering trainees to do things, but we also don't want to leave them in the lurch. We want to make sure that they feel, you know, feel involved, but, you know, also not overwhelm them with tasks either. Thanks for your time. This is obviously a huge topic of abdominal trauma, but this was sort of a broad overview of the key points that we want to discuss.
So thank you, Dr. Fingerman. We'll open up the floor to any questions. If you have anything, write it in the chat or raise your hand. I want to go right to your area of expertise, though, right off the bat. And I know this probably won't come up in a lot of unstable patients, but from a regional approach, what can we do for trauma patients to help with pain control, especially in abdominal trauma?
Sure. I mean, there's many options. Obviously, either, you know, pre or post. Typically, pre-op blocks are sort of not on the table for these individuals. We look at tap blocks, for example. Tap blocks are more of a somatic pain block, sort of incisional pain. Other options, if coagulation is okay, we can do epidurals, and neuraxial technique. A lot of folks are starting to employ erector spinae in trauma, because erector spinae, we've done erector spinae blocks in people that are basically, frankly, coagulopathic. I've done erector spinae blocks in people with platelet counts of 35,000, for example, on the OB floor with people with gestational thrombocytopenia. So I think that truncal blocks, fascial plane blocks are really the future, because we're not around any major vessels. We're not around anything that's important like the spinal cord. There's been no case reports of any neuraxial compromise, you know, any sort of spinal cord compression or hematoma after erector spinae blocks, for example, that I know of in the literature.
So not a bad skill set for someone in trauma to know, you know, having that regional background.
Absolutely. It's always good to have more block jocks around. Always good.
Well, Dr. Knittl, if I may, I would like to ask Dr. Fingerman about our criteria for extubating these patients in the OR, or just bringing the patient intubated up to the ICUs. So what are the things we are putting into account? Just keeping the tube in, or just, you know, proceeding for extubations, or how do we do that?
Yeah, sure. I mean, I think all of us on this call, if we polled the audience, we would get different responses for criteria. For me, it's about the main things like hypothermia, acidemia, coagulopathy. I think those are the key things to look at. You know, you have a cold patient. For me, anyone who's 34, you know, 34, 5 and under, it's going to be hard to wake them up, and it's challenging. Someone's coagulopathic. You know, and they didn't really allude to it, but, you know, a lot of these laparotomies are damage control. You know, surgeons want to get in there. They may leave the bowels in discontinuity. Obviously, someone with an open abdomen. So we need to be judicious with our fluid management, for example. If they're going to come back to the operating room and their bowels are swollen from getting too much fluid, it's sort of a dynamic balance. You know, other comorbidities, I think, how much volume have they gotten? So I think that the main things for me are coagulopathy, how acidemic are they? Are they on lots of pressors? I mean, I'm not a big fan. If someone's on some phenylephrine or some low dose levofed, but if we're running a lot, triple pressor therapy on them, obviously I'm not going to extubate them. Or if they're coming back to the OR, they may have a Bogota bag or open abdomen. So I would just leave that in place. So that's a good question though.
I think that's a really good point you brought up about our role in terms of things like bowel edema and our resuscitation. And it's important to recognize how much of a role we play in that and how we can impact what the surgeons do and what they have to do. So, anytime they cut open the abdomen, the goal is to close it back up. And if we're not careful with what we do in terms of our resuscitation, we can directly limit their ability to do that. And so I think having that communication between both sides and us recognizing from the anesthesia side what's going on and what the plan may be, what the injuries are, will directly impact how we resuscitate this patient.
Yeah, absolutely. I mean, if you're using a Belmont, for example, you can easily dump 4 liters of crystalloid in before you know it. You take someone who's 70 kilos, that's a lot of volume, plus blood products, plus third spacing. It really adds up quickly.
So on that note, real quick, with the communication with the surgeons and them having an open abdomen in front of you, it's not uncommon for them to ask us about how things look for them to close. Can you go in a little bit to what information they're looking for, what we're looking for from the anesthesia side to help guide them in terms of closing the abdomen?
Yeah, sure. I mean, I think some of this is hemodynamic stability. You want to make sure that you're not getting into someone who's going to develop abdominal compartment syndrome, for example. So we may look at urinary output. That's a whole other talk in and of itself. It's very hard to use urinary output for perfusion because, these things are massive ADH responders. So you may not get a lot of urinary output, for example. So using urinary output is just one tool in the armamentarium. I think we look obviously at peak pressures, anything that we're getting. They may sort of do a surrogate closure. Maybe you start to close and all of a sudden you see peak pressures going above 35, 40 in a non-obese patient. That definitely has me concerned. So I'm a bit conservative with these things. I think the last thing we want is we have them close and then they're flying downstairs, 6 hours later with someone with abdominal compartment syndrome or worse. I've also seen people have to get bedside laparotomies up in the ICU. And I'm sure you've probably seen that a few times where there's no time to get down to the operating room. So I think we need to be very cautious with closures in these large cases.
Yeah, and I think the peak pressures is a very good point that we watch the vent very closely as they close the abdomen to see what type of effect this is going to have, because it tends to get worse before it gets better in terms of the edema and inflammation.
Yeah.
Any other questions that people have? We have a couple more minutes for discussion here.
Yes, can I have a question? In a young penetrating trauma victim with no other morbidities, what is the minimum blood pressure do you tolerate?
Yeah, that's
And
a great
how long?
question.
How
That's a
long?
great question. I'll tolerate it typically. I mean, I personally like a MAP of 55. Again, that's sort of like, throwing a dart at the wall. I think you'll get different answers in this room, but I think permissive hypotension or sort of relative blood pressures are very important. I think we get very caught up. A lot of patients that we have of underlying cardiac disease or just elderly. The elderly folks are different. I like a MAP of 65, and a lot of the data speaks of a MAP of 65 to prevent any AKI, acute kidney injury. I'll tolerate a MAP of 55 in these individuals. I mean, these are folks that may come in and they may have a MAP of 40 and they're talking to you in the trauma bay. They may feel a little woozy, but they're still conscious. So for me, a young, healthy with no other comorbidities, a MAP of 55 for me.
Thank you.
I'll toss out, I completely agree with that. And I think that permissive hypotension definitely has a role for us in trauma. I would add that I would check some labs because the pressure may not indicate a problem, but when you see a dropping bicarb, you see a rising base excess, a rising lactate, especially in young people. Dr. Fingerman's right. Yeah, they may have a MAP of 40 and be holding on, but they're really 3 wheels off the cliff driving 80 miles an hour. They tend to hold on until they're dead. And so looking for those other signs that may tell you that they're struggling more than their blood pressure is letting on. Any other questions, comments? Otherwise,
Yeah.
I think we'll move on to our last talk of this session. Thank you very much, Dr. Fingerman.
Thank you very much.
Our last talk for this session is by Dr. Jing Zhang. She's a graduate of our program here at WashU and is now one of our trauma faculty. And she's going to be talking specifically about pelvic traumas. So Dr. Zhang, I have your slides up, and I think the floor is yours.
Thank you, everyone. Again, my name is Jing Zhang. I'm an instructor at Washington University in St. Louis in the Department of Anesthesia. My interest, I'm a generalist, and so I do a little of everything, but my interests are in trauma anesthesia, of course, and also education. Can everyone see the slide that I have up? Perfect. And so today we're going to talk about the anesthetic considerations in pelvic trauma. I have no financial disclosures or conflicts of interest. So first, to go over a little bit about the background of pelvic trauma. So in terms of mechanisms of injury, the biggest mechanism of injury and most common is going to be high energy impacts. As you can imagine, anything that could cause this to the pelvis is going to be most likely a very high injury impact. So those would be things like falls from a great height, high-speed motor vehicle collisions, motorcycle collisions, or pedestrian versus motor vehicle versus bike, etc. The other type of mechanism injury is a little less common, and that would be low energy impact. You see this mostly in the elderly and those with any kind of underlying conditions that would make them more susceptible to fractures. In terms of prevalence, many studies have been done in many countries. A study out of England showed that in pelvic trauma made up about 5% of all traumatic fractures and 10% of all severe traumas admitted to level 1 trauma centers. And then in terms of things associated with pelvic trauma, as I've already mentioned, this is usually caused by high energy impact. And so because of that, isolated pelvic trauma is actually fairly rare and only accounts for about 30% of pelvic traumas. And the majority of traumas that you will see if they have pelvic trauma are polytraumas, in which multiple other areas will be affected too. And specifically, the presence of pelvic trauma in general highly correlates with the severity of trauma. And so most likely your patients that you see with pelvic traumas are also going to have multiple injuries beyond the pelvis. In terms of mortality, one study found that 10 to 15% of patients who arrive in the emergency room arrive in shock if they also have a pelvic trauma. And then one multi-centered study done in the US showed that the mortality rate for patients presenting with pelvic trauma can be as high as 32%. And that in the first 24 hours, most of that mortality is due to hemorrhage. Whereas after the first 24 hours, most likely you're going to die from multi-system organ failure. And then in terms of source of hemorrhage, the things that can bleed in the pelvis, you've got bones, you've got veins, and you've got arteries for the most part. Things to keep in mind is that the pelvis can hide multiple liters of blood. And so again, just like the abdominal compartment, it's a place where you could very easily bleed out without ever noticing any external blood. What's interesting is that the majority of bleeding in the pelvis actually comes from the venous system. One study found that actually multiple studies found that 70 to 80% of the bleeding comes from the venous system, whereas only about 10 to 20% of the bleeding comes from arterial injury. And then in terms of going over a systematic approach to pelvic trauma, I will go over each one of these points in more detail. But in general, we want to first reduce the amount of blood lost. Next, we want to work on volume resuscitation. And then, of course, maintaining thermoregulation, as Dr. Fingerman spoke about a little earlier, is incredibly important in patients that we think are going to bleed. And then we'll talk about preventing infection and why in this patient population it is even more important. And then we'll touch briefly on definitive management of their pelvic fractures and pelvic trauma, and then touch on the importance of the multidisciplinary team. And so first, we want to talk about reducing blood loss. And so this comes in multiple stages. So initially, patients in our system are going to be evaluated by an emergency medical technician out in the field. And so most likely out in the field, if they were to find unstable pelvic fracture, they would apply some kind of pelvic binder, be it on the screen. You see multiple types. It can be as simple as simply a sheet that's wrapped around the pelvis to more commercially available things like a SAM splint or a pelvic binder. And the nice thing about all pelvic binders in general is that they reduce the potential volume of the pelvis, meaning that they reduce the amount of bleeding that can go into the pelvis. Specifically, this is very helpful for venous bleeding, which, as we talked about, is the majority of bleeding in pelvic traumas. Pelvic binders can also reduce additional soft tissue injury, and some studies do show that it decreases the volume of blood resuscitation that is necessary. Unfortunately, the studies are a little equivocal about whether it improves outcomes in the long term. And then another option in terms of blood loss reduction or blood loss reduction is preperitoneal pelvic packing. It's something that can be done in the emergency room or in the operating room by either your ED physician or your surgeon. Basically, it involves a midline incision from the umbilicus to the pubic symphysis, after which packing is placed in space between the peritoneum and the pelvic ring. And then, of course, there are other forms of temporary mechanical stabilization to stabilize the pelvic ring, such as external fixation, C-clamp fixation, anti-shock iliac screws, etc. Next, I wanted to touch on volume resuscitation. As we have already mentioned, the primary cause of mortality is blood loss in the first 24 hours. First thing to think about is access. Of course, anything from multiple large bore IVs to a RIC line to a cordis can be used. In our hospital setting, we prefer a cordis, especially in these cases of multi-trauma and major level 1 traumas, because of your ability to give blood as fast as possible. Something to think about, just as Dr. Fingerman mentioned, for abdominal traumas. In pelvic traumas, it is also preferable to avoid femoral access as able. Obviously, if for whatever reason that is the only access you can get, then it is better than nothing. But as you can imagine, if you place a cordis into the femoral veins, you may very well be dumping all of your volume resuscitation right into either your pelvic region or any further damage in your abdominal region that you've also sustained. This is, I think, where we as anesthesiologists can help the team in managing this patient. In our institution, we as trauma anesthesiologists will go down to the trauma bay to help them assess, but also to kind of be an extra pair of eyes. And if we see that the emergency room physician or the surgery resident is going for a femoral line in one of these cases, we can have the option to step in and say, hey, have you considered placing an IJ or subclavian, something that is going to be draining into the superior vena cava. Another thing I wanted to mention is our preference for blood products in terms of volume resuscitation. So at this hospital, we are lucky enough to have access to whole blood as well as packed red blood cells. And so for our protocol for trauma patients, we start with whole blood. And of course, I know that not everyone has access to whole blood. The advantages of whole blood is that studies have shown better outcomes. It causes less coagulopathy, and especially in the trauma patient, it is the preferred volume to use. What we have access to in our hospital is that our first box of MTP or massive transfusion protocol comes with 6 units of whole blood. After we go through that first box, then every other subsequent box is filled with a 1-to-1 to 1 ratio of packed red blood cells to FFP to platelets. The other thing I wanted to touch on is our mode of rapid transfusion. So at our institution, we have access to both a Belmont, which is the thing you see on your left, and then a level 1, which is the thing you see on your right. I'm not in any way endorsing any type of rapid infuser over another. I'm just kind of showing what we have access to. At our institution, we do have a preference for the Belmonts, especially in these large volume resuscitation efforts, solely because, as you can see, the Belmont can hold up to a 3-liter canister, and you can hang multiple units of blood at the same time. The other nice thing about a Belmont is that it warms the blood, and you can infuse as quickly as 1 liter of crystalloid at a time per minute, and then their max speed for blood is of course a little bit slower. We already touched on this, but we do use permissive hypotension in our trauma patients, specifically mostly because they're young and healthy. MAPS, some people use MAPS of 55 or 50. Other studies have looked at systolics of less than 90 versus less than 80 with pretty good outcomes, again, in this young, healthy trauma population. We are also fortunate enough to have access to ROTEM in terms, or rotational thromboelastometry, in order to guide our resuscitation efforts in terms of what blood products to use. Next, I wanted to touch on the importance of thermoregulation. So the advantage in our trauma setup is that we have a dedicated trauma OR that is kept purely reserved for traumas. And that room is kept incredibly warm, I would say uncomfortably so. And that is to help us in terms of maintaining thermoregulation in these trauma patients. Here we have a slide depicting the triad of death, or the lethal triangle. And so you've got patients who bleed a lot, and because of that, they get hypothermic. And when they get hypothermic, they get coagulopathic. Once they get coagulopathic and bleed too much, they make a lot of lactic acidosis, which makes them acidotic, which then decreases their cardiac performance. And then this cycle, it's a little evil cycle there. And then other considerations that I will touch on briefly. So patients with pelvic trauma do have higher risk of infection because oftentimes you have other bowel injuries, and so their wounds are essentially bathing in fecal matter. Otherwise, we just wanted to touch on definitive treatments. You can do arterial embolization for those who have arterial injuries, and then of course at some point your surgeons will want to do some type of internal fixation to stabilize the pelvic ring. And then in general, I know we've already mentioned this multiple times, but it is incredibly important in pelvic trauma, in all trauma, but especially pelvic trauma, to use a multidisciplinary team where you're communicating constantly with everyone else on the team, because you've got trauma surgeons, you've got emergency room physicians, you've got the anesthesia team, you've got the ICU doctor, you usually have an orthopedic surgery team involved too, as well as possibly a urologic surgery team involved too, depending on the damage. And so communication is key. And then in general, in conclusion, we've already talked about the main things to think about in pelvic trauma is blood loss reduction, volume resuscitation, maintaining thermoregulation, preventing infection, and then definitive treatment, and then of course a multidisciplinary team approach. And with that, those are my references. Thank you all so much for inviting me to participate in this, inviting us to participate. And I'll open it up to questions.
Thank you very much, Dr. Zong. And that is our last talk of this session. So we have a few minutes left for questions. If people want to write something in the chat or speak up or raise your hand, we'll open it up to anything for any of our speakers. Actually, for the talk, we'll try and get you an answer. I think your point about multidisciplinary approach and kind of this, some of the other options, we don't often take these patients to the operating room. We end up going to other locations, and most of the time, I know when I see pelvic trauma, the first thing I'm thinking is that we're going to interventional radiology. So I think it's just important, that you start thinking about that right away, that, for us, this is a remote location. This is not where we have as many resources, but we have to practice like we would in the operating room and be able to manage, a massive resuscitation in a different space. So I think, kind of a theme through all of this is planning and anticipation of what may come based on the injury and the mechanism and what the surgical approach may be. Dr. Alanoglu, do you have anything to end with?
I may, not maybe the pelvic traumas, but I would like to ask a general question to Dr. Zong about our, organization about the general orthotrauma patients. So what kind of a thing we have, just maybe we can get into a little bit more into details for the orthotrauma patients in our, especially in part 2 in, the orthotrauma pod. So what kind of a thing we have, how many rooms we have, how many resources we have, different resources, regarding the fact that we still have some like 5 minutes, maybe a couple of minutes, we may talk about this thing and you just give the audience an insight what we have here.
Absolutely. And so in terms of resources available specifically for orthopedic traumas, so as I already mentioned, in this hospital, we have a trauma anesthesia attending that is on 24/7, meaning that at any time of the day or night, we have a trauma anesthesiologist who is looped in on all level 1 traumas that are paged out to the emergency room. And that means that we're able to physically respond and be physically present for all level 1 traumas. And that's very nice because, as we all know, some traumas, they come in and you have many hours to work on them and they'll get stabilized in the emergency room. And then we have other traumas that come in and they may only spend 5 minutes in the emergency room doing the briefest of level 1 assessments before we roll them straight to directly to the operating room. And then in terms of for orthopedic traumas, we also have a orthopedic trauma call team in terms of the surgical setup. And so there is someone from the orthopedic surgery department who is on trauma call 24/7. They are also in-house and so can respond very quickly. And then, excuse me, in terms of the number of ORs, we usually do all orthopedic traumas in our pod 2 ORs. And so we have, I believe, at least 10 to 15 OR bays that are available. But again, we specifically reserve 1 to 2 rooms that are specifically for traumas that are completely set up in terms of the anesthesia department. And so this room is, the machine is always checked at least twice a day. We have ET tubes of multiple sizes already set out and styletted with a syringe in place. We usually already have a video laryngoscope out with multiple size blades available, as well as even things like arterial line setup in a little bundle and large bore IV setup in a little bundle with all of our fluids already either spiked or ready to be spiked in instant, such that if you have that level 1 trauma that has to come up within 5 minutes, that you're able to start, you're able to have everything you need very quickly.
If I may, I would like to comment just a little bit about the key role of having a trauma attending always available, because the trauma attending has a unique role for actually coordinating all the ORs with the ED, emergency department, and all the other resources, because the trauma attending sits in a position that he is aware of what's going on downstairs in the ED, what's coming in upcoming minutes or hours, whatever. And we are always in touch with the emergency room, that what's cooking over there. And on top of it, we are the ones who knows the exact amount of resource we have. And it's very important for the resource utilization, especially in the after hours. So the trauma attending just dedicated his or her, primary time to coordinate and to manage with the front desk, with the OR, with the surgical teams, with the ED. So I guess having a qualified trauma attendings is one of the most important part of a well-organized trauma service. And I guess we have quite an amount of well-organized and well-trained trauma attendings here, and that's the key of the success of this program. I don't know what Dr. Kinatel will add on top of this thing, but
Yeah,
still.
I mean, we're very fortunate here to have a lot of different departments that are involved in very heavily indebted to trauma, and work very hard to work on a trauma patient from multiple different angles. And to Dr. Alanoglu's point, yes, we have a lot of people dedicated here. We have a lot of roles in the Department of Anesthesia, but I think, looking at this session, what we also do is we do have a different approach to a general anesthetic in a patient than in other areas of anesthesia. And trauma is a disease process that's separate. And now that we really recognize that, we can treat it as such, and our approach and tailor our approaches to the patients and to the disease a lot more. What we do in trauma is not the same as performing a general anesthetic on a different patient for an elective case. And I think as this is being recognized and we, adjust our approaches to that, we will provide better care. So with that, I think that is the end of our discussion period and the end of this session. And so I want to thank Dr. Alanoglu. I want to thank all of our speakers, and definitely to the organizers of this conference for this opportunity. We're very grateful here at WashU to be able to have this have the floor to tell you how we practice and what we like to do. So thank you very much for all of this.
Yeah. Thank you.
All right.